So good afternoon, everyone. It's hard to talk after Dr. Al-Ghofi, but we'll switch the gear from the coronary to the structural intervention. So today I will talk about left atrial appendage closure, especially with Watchman Flex device. My name is Mosa Abbadi. I'm consultant intervention and structural heart at Prince Mohammed bin Nasser, Jazan. So as you know, atrial fibrillation is the most common type of cardiac arrhythmia. Its prevalence is around 2 to 4% for worldwide population. And the incidence of, or the prevalence of atrial fibrillation increase with age. Around 18% over age of 85 suffer from atrial fibrillation. Patients with atrial fibrillation are 5 times more likely to have a stroke, and 1 in 6 stroke occur in patients with atrial fibrillation. Stroke is the #1 cause of adult disability worldwide, and AFib-related stroke are highly debilitating. And as you know, in non-valvular atrial fibrillation, more than 90% of the stroke causing from the cardioembolic event is occurred because of left atrial appendage thrombus. So what is the left atrial appendage? It derived from the left wall of the primary atrium, which formed during the 4th week of embryonic development. It contains high concentration of atrial natriuretic peptide or atrial natriuretic factor, and the adult left atrial appendage size is around the size of the thumb, and the ostium may range from 10 millimeter to 40 millimeter, depends on the size of the left atrial appendage, and we'll come to that later on. And the left atrial appendage anatomy varies in shape, could be cactus, chicken wings, windsock, or cauliflower. Pain #1, the left atrial appendage is not the appendix of the heart. The left atrial appendage is an actively contracting structure. Its emptying and filling may be affected by LV function, and the left atrial appendage function as a decompression chamber during the left systole and during other period when the left atrial pressure is elevated. The left atrial appendage may maintain left atrial pressure through activation of the stretch-sensitive receptor and the action of atrial natriuretic factor. So, in patients with AFib, at higher risk of stroke who are either unable or unwilling to take oral anticoagulants because of associated risk, side effect, or medical reason that could also result in high risk of bleeding. Left atrial appendage closure device reduce risk of stroke as well as long-term risk of bleeding, which is associated with oral anticoagulation in patients with atrial fibrillation. Going to the evidence, in 2019, American Heart Association a focus update on atrial fibrillation labeled as Class 2P to do a percutaneous left atrial appendage closure in patients who have contraindication to long-term anticoagulation. More recent update in 2023, it gave Class 2A for patient who has contraindication to long-term anticoagulation due to non-reversible cause. And again, Class 2B for the patient who has high risk of major bleeding on oral anticoagulation. And it is difficult to strike a balance in stroke and bleeding risk. If we take the same patient who has CHA2DS score of 3, the annual risk of stroke will be 3.2. If his has-bled score of 2, then his annual bleeding risk is 4.1. If his has-bled score is 4, so his annual risk of bleeding will be 8.9. Not only this, if he has bled score is 4 at 1 year, so his estimated 10 years bleeding risk will be 60%. And taking in consideration that the more patient getting old, the more risk of bleeding regardless of the has-bled score. So, according to NCDR Pinnacle Registry, despite introduction of NUAC or DUAC, still around 40% of patients who is eligible for anticoagulation not taking their anticoagulation therapy. Going to the evidence, Protect AFib trial published in 2009. It was comparing Watchman versus warfarin, around 700 patient open label study. The conclusion was left atrial appendage was non-inferior to warfarin for composite of stroke, systemic embolism, and cardiovascular death. And there was significant reduction in hemorrhagic stroke in left atrial appendage arm, taken in consideration because since early introduction of the left atrial appendage closure, there was high early procedure complication around 8.9. Afterward, Breville trial, again comparing Watchman versus warfarin, 400 patients. Again, Watchman was non-inferior to warfarin at preventing stroke or systemic embolism from 7 days post-procedure up to 18 months. Similar efficacy endpoint as Protect AFib trial, and lower procedure complication because mainly of experience-dependent outcome. Then, a 5-year meta-analysis of Protect AFib and Prevail trial show significant decrease in hemorrhagic stroke, around 80 to 85% in left atrial appendage closure arm, significant decrease in major bleeding after 6 months. I mean major bleeding require transfusion or hospital admission, and comparable rate of ischemic stroke to warfarin. Overall mortality benefit driven mainly by fewer hemorrhagic stroke and bleeding event in left atrial appendage closure arm. More recently, Prague 17 trial, again comparing left atrial appendage closure with either Watchman or Amulet versus NOAC, mostly apixaban. Again, left atrial appendage closure was non-inferior to NOAC for a stroke, TIA, bleeding, and cardiovascular death. Lower rate for significant bleeding in left atrial appendage closure arm on long-term follow-up. So again, bleeding is still an issue, especially even with NOAC or DOAC, and the most safest one, apixaban. More recently, Pinnacle Flex trial done mainly at US, 400 patients, comparing Watchman Flex for non-inferiority to safety and efficacy. The enrolled patient with high risk of stroke and high risk of bleeding. Again, the study made the primary safety and efficacy endpoint, and based on that study, the Watchman get FDA approved for device in July 2020. Again, high implant success, around 99%, and very low risk, around 0.5% of event. Same in Pinnacle trial, again, at 12 months, the closure rate was almost 100. I mean, there is no device leak more than 5 millimeter. And again, for 24 long-term outcome, it has sustained safety and efficacy. Recently, Sherpa's study, which is registry-based study, enrolled around 97,000 patients from 2020 to 2022. The study population were older and has higher risk profile. Again, procedural success around 98%, and very few risk of event, 0.5 all-cause death, 0.2 for all stroke, and only 0.4% for patient has pericardial effusion required intervention. At 45 days, around 88% has complete closure, I mean no device leak, and around 98% clinically relevant outcome of less than 3 millimeter device leak. If we look to the evidence from the beginning till current era, the procedure success is around 90% when the device introduced, and now it reached up to 99%. Taking into the account, around 50% was new operator at the beginning, and now around 70% of new operator. So this means that Watchman or left atrial appendage closure device are more familiar even for the new operators. In regard to the complication and outcome, the complication rate was higher at the beginning, with mainly pericardial tamponade, with more operator experience and more development of the device. Now, the pericardial tamponade is less than 1%. I mean pericardial tamponade requiring intervention. So, what is the patient criteria for Watchman? Patient who has non-valvular atrial fibrillation, patient has increased risk of stroke and recommend to start anticoagulation, and patient is suitable for short-term anticoagulation but deemed unable to take long-term and oral anticoagulation, and patient has appropriate rationale to seek non-pharmacological alternative to anticoagulation therapy. So we'll talk more now about Watchman Flex device, and Muhammad, he will show it later with the device. So with the new Watchman Flex, it has full recapture, reposition, and redeploy capability for precise placement. It has around 77% reduction in the metal exposure, and more than 80% of contact point for sealing and divide and avoiding of leak. Once you form the pool, or the ball, it will be fully rounded and designed to safely advance maneuver within the left atrial appendage. Again, the device has 2 rows of J-wire or dual row of precision anchor, which is designed to provide optimal device engagement and avoidance of device embolization. Boston Scientific recommend either CT or TEE as planning for the procedure. I prefer CT as the baseline because it will give the optimum fluoro angle. It will also give the axis of the atrial appendage and the exact site of septal puncture. Procedural planning, we have baseline left atrial appendage echo, procedural echo, and follow-up echo. In the baseline, we need to do TE to confirm absence of thrombus, as presence of thrombus is contraindication for left atrial appendage closure, to measure the LA ostium and shape, to measure the LA length or depth, to check for pericardial effusion as a baseline before the start of the procedure, and to get general left atrial appendage anatomy like axis, pectinate, bustle, number of loops, and location. Why is important to measure the ostium at different angle? We need to measure the ostium as 0, 45, 90, and 135 because the LA appendage ostium could be oval, circular, or elliptical, and we should take the largest ostium size to determine the device size. And regarding to the device sizing, the LA depth should be approximately half of the implant diameter or longer, and the left atrial ostium should be around more than 14 and less than 31.5 millimeter, because with the Watchman Flex, the sizes range from 20 to 35. With the new Watchman Flex Pro sizing, they introduce a size 40 millimeter, which can cover up to 36 millimeter diameter of the left atrial appendage. In regard to the septal puncture, the goal of the puncture to be coaxial to the left atrial appendage, and the ideal location of the puncture as inferior-posterior position. As you see here in bicaval view, you need to be more inferior to get more coaxial to the left atrial appendage, and in the short axis view, you need to be more posterior to get more coaxial to the left atrial appendage. Implant deployment method, I will not talk in detail in this because we'll show it on hands-on. Once you reach the ostium of the left lateral appendage, you can retract the sheath till you form the ball, which is twice bigger than the sheath. Once you form the ball, it will be safe to maneuver or to play with the device at the risk of perforation. Here is almost nothing. So once you form the ball, there is a two-way of deployment, either unsheathing or advancing method or combination of both. Once you deploy the device, you should assess with the BICE criteria, which is position, anchor, size, and seal. The position need to be at the plane of the maximum diameter of the closure device, should be at or just distal to the left atrial appendage ostium. For the anchor, we'll talk to that later on to do tuck test to make sure that the device is well anchored to the left atrial appendage wall. Size to assess the compression at 0, 45, 90, and 135. We need to have range from 10 to 30% compression range. Then after that, we have to make sure there is good sealing with the acceptable is less than 5 millimeter leak. For the position, you need to land the device at the ostium or less than 2/3. We don't want less than half or more than a third because there is risk of device embolization. To assure that device is well anchored, you need to do tuck test, which is basically, Muhammad will show it to you later. You just open the hemostatic valve, then you just pull back the deployment knob and hold it for 10 seconds to make sure that the device is not moving from its place. You need to do it like twice or 3 times to make sure that the device is well anchored to the left atrial appendage. For the sizing, you need to assess for compression. You need to measure it again in all views. The compression range from 10 to 30, but personally, I like the compression range to be in 20% to make sure that the device is well anchored and there is no risk of device embolization. Again, the size or the shape of the device will be changed based on the percentage of the compression. It could be marshmallow-like, bell-like, hot dog, or other inverted marshmallow-like. Once you are happy with the position, you assess for compression, then you need to assess for device leak. The acceptable leak less than 5 millimeter, but if you have leak, you need to make sure that the leak is not more than 5 millimeter to avoid device-related thrombus. So again, bus criteria consideration, position matter. You need to do a 10-second hold or more to allow for proper nitinol expansion and anchor engagement. Higher distal compression may affect the anchor engagement and the shape of the device. Tug depth is greatly dependent on the quality of tug. Embolization are often related to inadequate position and or low compression. Again, if you are not happy with the position and you are not happy with the compression, you can reposition the device by either doing full recapture or partial recapture. Partial recapture, you just unsheath or sheath again till you form the ball, then you can redirect the device to the perfect position, or you can do full recapture, so which will recapture the whole device. And we'll show it to you later on hands-on training. So once you are happy with the position, you need to rotate the deployment knob counterclockwise 3 to 5 times till you have released the device. After you finish, you need to do assessment with imaging, either echo or CT at 45 days or more, to assess for device position, device seal and residual flow, to assess for device-related thrombus and residual septal shunt. Afterward, you have two options for the anticoagulation or drug regimen. The option number 1, oral anticoagulation plus aspirin for 45 days, then DAPT for 6 months, then aspirin alone. Or what I prefer is just DAPT for even 2 months, then aspirin alone lifelong. I will stop here and thank you.